Welcome to Labcast, a podcast about the medical laboratory science profession, brought to you by MedLab Convo. To get notified once we drop an episode, you can do well to subscribe to all our social media platforms at MedLab Convo. For questions, feedbacks, and shout-outs, you can do well to send a mail to at medlabconvolabcast@gmail.com. Thank you for listening.
Joe had been on dialysis for 5 years, waiting for a kidney. Finally, he gets a transplant. The surgery is successful, his lab value improves, and hope is restored. But weeks later, his creatinine level spikes. Biopsy shows infiltration, and the dreaded word appears on the chart: rejection. For the patient and for their family, it's devastating. But for scientists and clinicians, it's a stark reminder of the complexity of the human immune system. That's exactly what we're exploring today. Organ transplantation is one of modern medicine's greatest achievements, but it's also a battlefield. Behind every success story, there's an ongoing battle: your immune system versus that new organ. And that battle can mean the difference between life and death. Even with immunosuppressants, studies show up to 20% of kidney transplants experience acute rejection within the first year, according to the American Journal of Transplantation for the year 2022. Today on Labcast, we're unpacking transplant immunology, why some organs fail, the science of rejection, and the cutting edge strategies to prevent it. Because understanding the why could save thousands of lives every year. I'm your host, Oluwadamila, and here with me is my co-host, Jesu Tosin. And
Hello, everybody.
we have two incredible guests with us. First, Dr. Olaleye Olajuyin, PhD student in biomedical science and researcher in kidney regeneration at University of Maine. Welcome, Dr. Olaleye.
Thank you so much. It's nice to be here this evening.
Dr. Olaleye is not a stranger to us, and he has been on several episodes on Labcast discussing and sharing his knowledge about transplant immunology and his research on kidney and kidney regeneration. Also joining us is MLS Samuel Gana, who is a postgraduate student in immunology at Usmanu Danfodio University, Sokoto. And Samuel is also an assistant lecturer at Newgate College of Health Science. Welcome and thank you for being here, Samuel.
Hello, thank you. Thank you for having me.
So I have my co-host go ahead now.
Thank you so much for such a beautiful intro. You're welcome again to our lovely guests. So let's start from the basics, right? Samuel, could you explain what transplant immunology is and why it's such a critical component in organ transplantation?
All right. Hello, everybody. Once again, thank you for having me here. In short, I'm just going to say it as just a simple sentence. Transplant immunology is the study of immune responses or immune reactions that occur anytime organs or tissues are transplanted from donors to the patient or their recipients. So it majorly deals with the series of events that leads to graft rejections. So the second question that says, why is it an important component in organ transplant? Is because looking at it from history, first time that an organ was they attempted transplanting, giving someone else an organ, they found out that the person rejected it so fast and it had multiple issues on the patient. So later on, science began studying to see why and what happened that the organ was rejected. And so that's how transplant immunology came into being. So this has led to us to understand that you can't just transplant organs anyhow, you can't give someone a tissue anyhow. There are certain things that would have to be looked into. Thank you.
Thank you so much for the elaborate response. So imagine a patient who just received a kidney transplant. How does the immune system recognize this new organ, and why does it sometimes decide to attack it?
All right. So this basically starts from the basic knowledge of immunology when we talk about self and non-self. Self antigens are proteins or things that are present in a person's body that are for him, while non-self are proteins or carbohydrates or things basically that comes from outside. And so in this case, a kidney is something that is coming from outside, although from people of the same species, and that's where the phenomenon, and that's where alloantigens come. And alloantigens are antigens from individuals of the same species. And so whenever someone receives a kidney, right, the immune system sees that kidney as non-self, even though that kidney is coming from someone else. Are we together? So as depending on the matching, sometimes the kidney can be matched for MHC, which is called major histocompatibility complex. That's present on all cells of an individual. However, there are some particular proteins that we call minor histocompatibility complex, which sometimes may not match. And because they don't match, the body sees that kidney as foreign. And once it sees it as foreign, it begins to mount immune pressure on the organ, thereby leading to graft rejection. Thank you.
Thank you very much, Samuel, for that elaborate response. So, Dr. Leye, um, we are aware there are different types of rejection. We have the hyperacute rejection, the acute rejection, and the chronic rejection. So, could you break down these types of rejections? Tell us the differences and which is most challenging to manage.
Yeah, thank you. So I'm going to start from where Samuel ends. So, basically he has talked about how some immune system cells can kind of mount response towards the organs that is being received by the recipient, and in such, after that, there can be rejection. So basically, we have like three type of rejection. We have the hyperacute, we have the acute rejection, and the chronic rejection. So the hyperacute rejection is the first one, which basically happens almost immediately after grafting. So it is not really common anymore because there is a lot of advancement as far as transplantation is concerned, because there's a lot of testing that goes on before the transplantation starts. So in this hyperacute, it happens almost immediately, maybe like minutes or hour after the transplant. So in this situation, it's just like the recipient has a lot of, antibodies that are very, very specific for the antigen that is coming in. So this can happen over time. Maybe, the recipient is already sensitized. Maybe the recipient has taken a lot of maybe treatment before, during birth, or there is a lot of antibodies or memories antibodies that are present in the recipient that they sense the antigen that is coming in immediately and they mount response towards it. And once they do that, they're going to make sure that they clog the blood vessels, the endothelial cells, and clotting starts immediately. There is fibrosis, there is cell death, and at that point, it is not reversible. So the best thing they could do is to find a way to make sure that patient survive by stopping that transplantation or finding means by which to help that patient. So basically, what we need to take in from that is that it happens almost immediately after transplantation. So the next one is acute rejection. So in acute rejection, it kind of happens like maybe days or weeks after transplantation. This also occurs as a result of maybe, like the immunosuppression they give the patient is not adequate, because most of the times, in fact, at most times they give most of these patients immunosuppressants to reduce their immune system activity. So maybe these drugs are not working, or maybe they are not sufficient, or maybe there is rapid activity of T cells that comes in, the cytotoxic T cells and all other immune system cells like the B cells and antibodies that are coming in. And because of that, they kind of cause vascular injury, they cause endothelial cells damage, they cause, inflammation, they cause necrosis and all of that. And eventually, the organ is rejected. So acute rejection takes place like weeks or days after the whole transplantation takes place. And the last of them is chronic rejection. To be honest, the chronic rejection is very, very dangerous. And the challenges, as far as this is concerned, is that it doesn't show any sign at the beginning. It's kind of rapid, progressive, continuously. So at this point, even when it starts, you can still do some blood work on the patient, and the GFR is fine. I mean, the glomerular filtration rate of the kidney is fine. The creatinine level is fine. The urea and the likes, they are fine. The creatinine clearance is fine. Now you think, oh, this patient is doing fine. But this damage happens over time, consistently, over the years. And by the time the whole damage has occurred, you just see that the scarring comes in, the blood vessels lose their function, the organ loses function, the graft is rejected, and this is not reversible. There is nothing they can do about it. In fact, the patient enter the end-stage renal disease directly stage up. And the next thing they need to do for the patient is to help maybe dialysis and all of that and looking for another transplant. So the most challenging of them, from my own perspective, from what I've explained, is the chronic rejection. So, when this acute comes in or hyperacute comes in, they immediately try to help attack the whole thing. Maybe they can see a drug to suppress the action. Maybe eventually they can still help that patient during those situations. But when it comes to the chronic, because it's kind of progressive and the damage is consistent over time, eventually there is no solution. The only thing they need to do is maybe another transplant.
Thank you very much for sharing that with us. I mean, like the chronic rejection sounds very fatal and scary because the fact that you don't even see any signs before the whole symptoms just come up all of a sudden is, I mean, very, very scary. But here's a follow-up question for you, doctor. Infections can be a tricky part of post-transplant life. So how do they interplay with the immune system and potentially cause organ rejection? Because yeah, the organ is fine, but eventually the transplant fails, and somehow you find out there's an infection somewhere. So how come infections can work against our immune system or cause organ rejection for a particular patient?
Okay. So when it comes to infection, this kind of treatment we talk about, the immunosuppressive drugs and the likes, it's just like you are using like a double-edged sword, because as much as possible, we are trying to help those patients to suppress their immune system so it's not going to act towards the graft that is coming in. But at the same time, we are also not helping the patient. So one of the things I want us to understand here is that the body does not naturally want to reject your organ. So, just like the body, the way it's programmed is to fight anything that is foreign. And that is what it's doing naturally, right? But now that we give immunosuppressants to reduce the activity of the immune system, don't forget that the body also loses its function to fight infection. So it's just like picking your poison. So in this situation, once the patient's immune system is suppressed, so there is no action towards the graft coming in, but at the same time, the patient becomes susceptible to a lot of infections. And some of these infections can be opportunistic infection, and some of them can be because you can have bacterial infection, viral infection, fungal infection can come in because the immune system is actually suppressed. So in that situation, for example, maybe there's some infection that is specific for the organ that is just coming in. Let's say kidney, there's something we call JC polyvirus. Let's say liver, there's something we call hepatitis. These are infections that could come in, and even some bacterial infection. In that situation, when this infection comes in, there are situations whereby the body also want to try to fight, right? So in that situation, even though the patient they're trying to suppress the immune system, this infection can also raise some antibodies to come in. And the tricky part is that the antibodies that come in, some of them can also be specific for the graft, for the antigens that are present on the graft. At the end of the day, the infection also produces antibodies that are more responsive towards the organ you are also trying to, take care of. So these are just the situations that happen. So when it comes to, organ rejection, infection, so two of them comes hand in hand. So eventually, the clinicians try to see how they can help this patient by picking or selecting drugs that can help them at the same time help them not to be susceptible to infection. Go personalized way, looking at each patient to see the best treatments they can give them. Yep.
Thank you very much. So apparently, the drugs that's supposed to make us feel better after a transplant can actually cause damage to our body as well. And I guess that's why the word immunosuppressant comes. The fact that you suppress the immune system means that the immune system gets weaker and can't fight foreign bodies. So, to Samuel, could you explain the role of T cell antibodies? You were educating us about, some of these things at the beginning of this episode, and I'd like you to explain the role of T cell antibodies and the concept of direct versus indirect allo recognition in organ failure, because you talked a lot about allo antigens and the like. So, thank you.
All right, thank you for the question. So, while I was speaking, I spoke about allo recognition. That's the recognition, or rather, the immune system recognition of an antigen coming from outside, but of the same species. So, I want to start from there to explain the roles of the T cells and antibodies. Now, when it comes to direct allo recognition, one thing we understand is that every tissue contains what we call dendritic cells, which are APCs. APCs is short for antigen presenting cells. Now, what happens is that once an organ is transplanted, yes, once it goes from the donor to the recipient, those APCs that are in the donor will interact with the recipient's T cells. And once they interact with the recipient's T cells, what happens is that they activate the recipient's T cells. And that is called direct recognition, or we call it direct presentation, basically. And once the T cell recognizes the MHC of another organ, yes, of another organ, of the donor, there is a direct destruction of the organ. Secondly, for indirect, sometimes the graft antigens are presented on the recipient's APCs, that's antigen presenting cells, which traffic them to T cells and activate T cells. Now, what T cells do is that there are basically we have the helper cells and the cytotoxic cells. So what the cytotoxic T cells do is that they directly destroy the organs, while the helper cells, what they do is that they activate or they help other organs to be able to perform their function. One of such organs is the B cell. Now, what T cell does is that it provides stimulation for B cells to be able to undergo what we call clonal expansion. That's the increase in number. Then they transform to plasma cells, then produce antibodies. Now, what these antibodies do is that they mediate destruction of these organs via different ways. So that's their function. So white cytotoxic T cells is associated with direct destruction of the tissue or the kidney in this case. T helper cells helps to coordinate the activities of other cells, and some of these cells are macrophages, some of these cells are B cells, and there inflammation ensues, and as inflammation ensues, the tissue is destroyed. Thank you. I think I answered that.
Thank you so much, Samuel, for such a wonderful take. To you, Samuel, from a scientist's perspective, what are the markers of rejection? The lab values, biopsy pattern, or imaging findings that raises red flag and an indication for organ failure and rejection.
Okay. I think from the beginning of the podcast, when Dami was introducing, she said that the creatinine levels spiked. And so the first, some of the early signs that we see is, even doctors spoke about it, is rising creatinine levels. Rising creatinine levels are one of the earliest markers. Of course, we are going to see an issue with the glomerular filtration rates for kidney now, the same proteinuria that's showing inflammation of the kidney. And of course, because transplant rejection is associated with inflammation, so you see some of these markers, early markers, as the issue, especially in hyperacute rejections. And of course, physically, you see the patient with some kind of physical reactions there. Then for imaging, of course, once they go for scan, you'll be able to see extent of you'll be able to see the extent of damage that is being done to the tissue. And if they're going to do biopsy, of course, they will be seeing a lot of inflammation, a lot of granulomas that will be formed on the side of the tissue. And of course, one thing again is that the blood vessels that are linking the new organ to the recipient's body would have issues, and so you see a lot of lysis, and of course, these are some of the direct. These are some of the direct things that we see as scientists. Now we say, okay, this person was going into rejection.
Thank you so much to Dr. Olaleye. When it comes to lab practice, one has to be very careful with medical legal cases and ethical concerns. There is an ethical dilemma when organ fails and patients return to the wait list due to the organ shortage crisis, while others haven't been able to even get a first-hand transplant treatment. How does this rejection impact organ failure, allocation, and sorry, please, let me just retake that. I'm so sorry, let me just retake that question. All right, so in medical lab practice, there is always a concern regarding ethical concerns and medical legal cases, and nobody wants that. So there is this ethical dilemma when organ fails and patient returns to the wait list due to the organ shortage crisis all over the world, while others haven't even had a first transplant. How does rejection impact organ allocation and patient survival rates globally?
Yeah, okay. Thank you. So I think I may not be able to talk about how this occur all over the world, but I will talk about maybe the United States. So at the moment, we currently have a lot of patients on transplant waiting list in the US. For instance, my area of focus, which is kidney, we have more than 100,000 patients waiting for kidney transplantation, in which less than 20,000 or 15,000 get kidney almost every year. So when we look at people that have already received a kidney and eventually the kidney fails, to be honest, it's a very challenging situation because they are now in another world. What I mean by that is because once they are maybe the organ fails as a lot of chronic rejection, If it is kidney, they place them immediately on dialysis and they start looking for new kidney. Now, at that point, some thousands of people are already on the wait list that have not even gotten the first kidney, right? While you are just coming in. So when it comes to the US, they kind of follow equity, justice, and fairness when it comes to organ practice. And they don't basically use the fact that, oh, you've gotten a kidney before, so you need to wait. No, they actually give kidney on urgency and priority. So what they do is that, for example, if that from one rejection, don't forget that that patient has already been highly sensitized. In fact, as a matter of fact, there's a lot of antibodies highly sensitized and a lot of challenges that that patient is facing. So if if they kind of look at the condition of that patient and they feel like, okay, they look, because there's a lot of scores they look. If the patient's score is kind of very low, that the patient need a kidney as urgently as possible. Sometimes they consider them more than the person that have not gotten before, if that person will still be able to sustain for a lot of time, even when he or she has not gotten kidney. So what I mean basically is that they look at the score, and just for us to know that not everybody will be fit to get new kidney or new organ. Some people, they can't be fit to enter that kind of, to enter the whole list, because they look at, maybe they have comorbidities, like maybe they are diabetes, they have crazy disease apart from what they have, that even they can't survive transplantation. So because of that, sometimes some patients will not be medically fit to enter those lists. But in a situation whereby there are some two patients, they know that this one will still stay longer than this person. Sometimes they consider that person more than the other person. So it's not all about, oh, you've got a kidney before, now wait for, I don't think they do that. What they do is to look at the score and see how far a patient can live before the other patient. So basically, they still follow the pattern of equity, justice, fairness, and look at how patients survive and the number of time the patients have to live and all of that. They put all of this into consideration before they decide who is the next person to get this organ or not. Thank you.
Thank you very much, Doctor. So earlier on we were talking about immunosuppressive therapy, and we talked about how you mentioned a particular word, which is it can be a two-edged sword. So how do we find a balance between preventing rejection by using immunosuppressants and avoiding infections or malignancies by the other side of this sword?
Yeah, I think that is a very good question. You know, this is one of the questions that is still kind of very difficult to answer as far as the transplantation field is concerned. Helping these patients to suppress immune activity, at the same time, helping these patients not to have infection or maybe not to go through cancer routes, right? So just like I said, like you repeated, double-edged sword, right? So when it comes to preventing the rejection, there's a lot of drugs that are available. They use steroid, they use some, inhibitors, some T cells and B cell suppressants and all of that, to make sure that these patients' immune systems are, suppressed, so they don't come, there is no situation whereby there is organ rejection and all of that, right? But as we are doing that, the patients also have the risk of having different infections like bacteria, viruses. In fact, viral infection are mostly common sometimes, like cytomegalovirus, JC polyvirus, like all these hepatitis and all of that. And at the same time, fungi can also comes in, right? So all of this comes in. In fact, when it comes to cancer, for example, one of the rampart one is skin cancer, lymphoma, and reason is because by the time we suppress all this immune system, sometimes some cells that ideally they should not continually to divide, they continue to divide because there is no immune system that acts against them. So one of the best way I think they can help most of these patients is to kind of use personalized medicine. That is, treating each of them according to the pattern of what they have, not just using one size fits all, general treatment. But in this advanced country like the United States, they kind of look at the lowest effective dose, that can prevent rejection at the same time minimize side effects. So they kind of look at the patient, look at the lowest effective dose they can give them that can at least suppress the immune system at the same time that will not predispose them to some other infections. Very challenging, right? But they do that. So most importantly, they look at the drug combination, they look at careful monitoring of these patients, and with time, they also adjust their therapy. That is why it is not good for you. Maybe somebody have had transplantation over time, you feel like, oh, I'm fine now, I'm not going to do anything. It's dangerous. But with time, they kind of adjust their therapy, look at their immune activity, help them to maintain balance and all of that. Sometimes they give them some antibiotics, some antiviral drugs, just to make sure that there is balance between all of this. So I think those are the best thing they do at the moment. So they go personalized way, looking at each patient and what is unique to each of them and try to help them to suppress the immune activity so that it won't reject the new organ at the same time, not leaving them defenseless. So these are the ways by which they help these patients to balance these two.
Thank you very much. Your response reminds me of therapeutic index, lethal dose, and the likes, and most importantly, the fact that every patient is unique and personalized care is very important. So, I would like to ask Samuel this question. We're now in the era of artificial intelligence and machine learning. So, what's your take on applying AI and machine learning in transplant immunology? Is there a possibility, or can we get to that point where computers can help us prevent organ failure?
All right, thank you. This is an amazing question actually. So far, it has come a long way, and I would like to say that there is still a long way to go. Because again, when we look at transplant rejection, when we look at this field, we are not just looking at one size fits all approach. We're not looking at. We have to look at first the things or what makes up for rejection, and we've looked at the major histocompatibility complex and the minor histocompatibility complex, which is usually often the problem associated with transplant rejection. However, I feel that with the way machine learning is going, with the way AI is going, it will help us determine some of these minor histocompatibility issues. I think that's, and if it helps us see these things early, we could prevent transplant rejection better. That's what I'm saying. And again, we are also looking at personalized medicine. What's for Mr. A may not work for Mr. B. So I feel that we are on our way. Yes, let me be political here. We are on our way, but there's still a long way to go as regards these parts. Thank you.
We are on our way is better than no movement at all. Yeah. So
Yes, of course.
with advancement like tolerance induction, mixed chimerism, and regulatory T cell therapy, do you see a future where we can eliminate lifelong immunosuppression for transplant patients?
This is an amazing question, actually. Okay, so we let me start this way. Whenever we want to tell the immune system to see this one as your own, we are basically trying to tell the immune system to tolerate this particular organ. And now, because the immune system did not see this organ as self, it made what's it called now? It made reactions against the organs. But I believe that again, for these ones, we are on our way because the issue with tolerance induction is that if you decide to tolerate, of course, other things can happen. right? Um, let's use the example for stem cell, where we have graft versus host, where the graft itself begins to attack the host. So, if I wouldn't say a time will come when we will not use immunosuppressants, because even some of these immunosuppressant drugs are actually anti-immune system, not just what's it called, not just chemotherapy. They are also immune drugs that tend to reduce the action of the immune system. But I believe that again we are still on our way, because we are not there yet. But I believe that a time will come where we'll be able to modulate the immune system strong enough to be able to tell the immune system to tolerate some organs, especially if with AI we are going to, if it's possible, when we get to the point where we are able to see some of these differences, I'm sure we could build models, especially in that time, models we built with the chiasma and regulatory T cells that will be able to help modulate and reduce the effect of the immune system against transplant. But for now, we are on our way. Let me stop there. Thank you.
Thank you so much. So to Dr. Olaleye, how does feed address ethical and logistical challenges when it comes to xenotransplantation, using animal organs and the unique immunological hurdles there?
Yeah, thank you. Before I answer this question, which is a very good and interesting question, just to add something to what Samuel says about this AI stuff. So, I'm just thinking about it like, imagine a world where now we have AI that can help to register every forms of HLA antigens that are present on every human and give a good database. Now, when it comes to issue of transplantation, that we can go to that database and continually search and see who and who match. That would be a big deal. And also, I just thought about a situation whereby AI can keep memory of every activity of every patient and can predict if this patient is going to have rejection of a particular organ or not. So I believe all of this will definitely revolutionize this field. That is just one thing I actually, think about. Now, when it comes to this aspect of xenotransplantation, sorry, please. Okay. So, well, let me just say that this is currently where the world of transplantation is going. Just like a meeting I attended, last month, where the doctors were telling us how they've done some transplantation. One of them told us they did pig transplantation, I think in Maryland, to human, and this person survived for like 3 months before he died. There is another heart transplantation in which from pig, and the person survived for like 6 months before he or she also died. So this is currently where the whole transplantation system is going, xenotransplantation. But that does not mean there is no hurdles, there is no ethical challenges that are attached to this field. Now, the first thing I'm going to talk about is the immunological hurdles. One of the challenges they face in this field is hyperacute rejection. Because just think about it, you are transplanting different animals. Just like, you are transplanting pig to human. We are quite different forms of animals to each other, right? So one of the first things that happens is hyperacute rejection. Now, reason is because because naturally humans, we have a lot of antibodies that are specific for animals, to fight animals, because they are not our own, like we are not 100% the same. So, for example, there is the antigen in pig known as alpha-gal. And humans, we have a lot of existing antibodies against this. So if this pig is transplanted to human or transplanted to human, you can be sure that there will be a lot of responses immediately, which is going to lead to massive destruction of that organ. Now, another thing is maybe, cellular rejection. Cell-to-cell interaction comes in. The T cells is going to recognize that, oh, these guys are foreign protein. It's going to mount response towards them. And the responses are very very, very strong. The cytotoxic T cell comes in, destroy all the organs, pass activity to the, the T helper cells. That one activates B cells, releases antibodies, and before you know it, the patient is just gone. So that is one of the first challenges. The next thing is risk infection. You know that most of these animals harbor a lot of pathogens, and these pathogens are not virulent to them. But once we as human take in such organ, you can be sure that there will be cross-species transmission of viruses. And even though a patient is getting new organ, the patient is also getting another problem. So I believe these are the immunological hurdles that are attached to xenotransplantation, which currently they are trying to deal with. Now, when it now comes to ethical challenges, ethical hurdles, a lot of them, there's a lot of animal advocates that they keep fighting that, oh, you don't use animals to do this, they can sue you for any reason. So at the moment, there's a lot of animal welfare and a lot of, trying to see that they regulate the use of animal, not just picking a pig and just use them for transplantation. So there's a lot of ethical concern about how human treats animals, which is part of the ethical challenges we're facing. So what I believe or what I think that the field could do to address this challenge, some of them are being practiced now, is genetic engineering. This person I told you they transplanted pig to, they did CRISPR-Cas9 editing of that pig kidney. And I think they did like 39 to 60 gene edition. So they edited a lot of genes, removed some of the gene, had some genes that are favorable to humans. Just like this alpha-gal I told you, they kind of edited those genes out, they inserted some other gene. So there is gene deletion, gene insertion consistently before they put that animal, which is quite fascinating, right? And that patient actually died, not because of that kidney, because the patient have multiple problems. That is the reason why the patient decided to use himself or for that clinical trial. That's the first thing I think they are doing at the moment. At the same time, strict screening and monitoring, and make sure that there is a lot of ethical rules that guides this, not to just pick up animal anyhow and use them for your experiment or for your trials. So I believe these are the ways by which they're addressing these challenges. But I believe there is a lot of success being achieved in this field and they're getting there. Yeah, thank you.
Thank you very much, Dr. Lair, for sharing with us. And so right now we're going to the this or that section, and basically you just have two options. You pick which you prefer, and just briefly explain why you do so. So first, to Samuel, we have CRISPR modified organs, just like Dr. Lay had discussed with us earlier, about using pigs and all of that. I think I've given you expo already. So would you prefer CRISPR modified organs or just gene editing generally?
Mm. Okay. Both of them have their own challenges actually. I'll prefer CRISPR-Cas9.
Wonderful and interesting choice. To Dr. Leye, do you prefer stem cell therapy or xenotransplantation?
That's a tough call. Okay. Well, I'm a stem cell person, but as far as this field is concerned, I'll go with xenotransplantation. Yeah.
Okay, xenotransplantation, meaning that you prefer that animal organs compared to just, stem cell.
Yeah,
Interesting.
because stem cells is just difficult. It's a long way to go.
Understand. So to Samuel, would you prefer personalized immunosuppressive regimen? Like Dr. Leah has discussed a lot about that with us, and you also shared your knowledge about immunosuppressants, or biomarker guided care that has to do with the histological part.
Mm, mm. Okay. Um, well, I'll prefer personalized care. I'll prefer personalized care. I'll prefer personalized care. Yeah. Because again, personalized care is picking a patient to study him and look at his complexity and what is specific to him. So, and even in that, you would still see part of biomarker guidance there. So I prefer personalized medicine.
Can I say something?
Yeah, sure, go ahead.
Yeah, I think the choice of Samuel is very interesting too. I also have been, go for that. But one of the things I also thought is it is not cheap. It is a crazy and expensive process. In fact, for example, in the United States alone, you are doing kidney transplantation, focusing on you alone, blah, 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 is almost 500,000 US dollar. Not to talk of, the priest plasmas, the whole of the blah, blah, blah. So I believe, just like Samuel said, I would have gone with personalized, but it is not cheap. So just not to balance our stuff. Thank you.
I know it's such a tough option. That the options are really, really tough. Sorry for putting.
Yeah.
Yeah. All right. Oh, it looks like we shouldn't end this episode. I mean, we have such an amazing set of guests this episode, but we have come to the end of this episode recording, and we often celebrate the miracle of transplantation, but today we've seen that it's really a delicate dance between surgical precision, immunology, and patient management. We've learned that rejection isn't just bad luck. It's a sophisticated immune response trying to protect the body and to overcome it, but needs science, precision, and innovation. Understanding the immune system is key to saving lives in transplantation. A huge thank you to Dr. Olaleye and Emile Samuel for breaking this down for us. For those in training, remember the future of transplantation lies not just in surgery, but in immunology. For our listeners, thank you for tuning in today's episode on Labcast. Remember, every transplant has a story, and science is consistently helping us write a better ending. Don't forget to subscribe, share this episode, and leave us your thoughts. For sponsorships and collaborations, drop us an email at medlabconvolabcast@gmail.com or connect with us on social media at medlabconvo. Until next time, stay curious and remember, medicine isn't just about science, it's about giving life a fighting chance.